going to introduce Dr. Candace Burton, who is a faculty member here at UCI in the Bill and Sue Gross School of Nursing here at UCI. She's a former domestic violence advocate, and her research focuses on behavioral and biological health effects of intimate partner violence. She's written extensively about young women's health, about intimate partner violence, women's reproductive health and sexual coercion, social media, cultural stressors, and many other areas. Is doing multiple projects now through the Initiative to End Family Violence, and has been just an incredible faculty partner and collaborator here. So we're thrilled that you're here today with us.
Thanks, Jane.
Candace.
Well, I need to start off by saying I'm completely overwhelmed because I was expecting to be here as a participant today, not as a discussant. So bear with me as I try to marshal my thoughts, of which I have many. As I was listening to the previous speakers, I was realizing that I have such a different background from so many people who do this work within academia. I was an advocate. I was a community advocate, and that's actually what led me into nursing, and nursing led me into scientific research. And so I'm going to try to present my thoughts on all these things from the perspective of a scientist, as a nurse, and as a clinician. And so first, I do want to say that one of the reasons I do what I do, one of the reasons I do this research and this work is because we cannot do this work in silos. We absolutely cannot separate law from healthcare, from community activism, from sociological exploration, from criminology, et cetera, et cetera. And it frustrates me to no end not to find all of us at all of the tables all of the time. So it's sort of bizarre to me to be here because I would not have expected to be asked to speak at a law-oriented event, and I have to confess I have barely dipped into Lee's book, but what I have read is sort of remarkable, and I really appreciate the incredible stance that she's taken and the effort it took to produce this kind of work and to make this issue transparent for us. So I think that the first things I want to talk about are from my own work as a scientist and as a researcher. I started what I'm doing because I felt like no one understood what intimate partner violence actually does to people. And I started out wanting to understand why it was happening. And the more I worked on that, the more I realized I needed to understand what was happening, not just from the physical act of violence, but the health and well-being trajectories of survivors. And so the work that I've been doing most recently actually has shown that there is cellular damage that persists and increases over time in people who have experienced abusive relationships. So I'm not just talking about bruises or broken bones or depression or PTSD, things that can be treated. I am talking about the devolution at the chromosomal level that results from ongoing stress, such as violence and abuse. So my work has shown that women exposed to intimate partner violence have something called telomere attrition. Who remembers their high school biology and knows what a telomere is? Anybody?
We didn't talk about those.
Yes, we're all old. So telomeres, the best way I can think of to show you this is to draw it. So if this is your chromosome, right? It doesn't really look like this, just by the way. But this is the familiar DNA double helix that we all sort of recognize. Chromosomes are actually very tightly wound strings of DNA, like a slinky. Okay, when it's closed up, it should be closed up. And telomeres are these things on the end that keep it that way. So imagine you have a slinky and you put a paper clip on the end of it so it can't unwind. Now, there is something called marginotomy that happens with telomeres. I know, big words. The theory of marginotomy says that telomeres shorten over time as chromosomes replicate, cells divide, et cetera, et cetera. They're supposed to do this because we don't want copies of copies of copies, because the more times you copy something, the more likely it is there to be an error, right? It's like, remember making copies of cassette tapes? And they'd eventually get really crackly when you copied it from your friend who copied it from their friend. Yeah. Or like old copy machines when we actually made mimeographs of things and they got really blurry. So that's the same thing that happens with our chromosomes. And telomeres are supposed to shorten so that eventually the cell will kind of explode and go away and it can't be copied again. What happens in women who've been exposed to intimate partner violence, and I have only studied this in women because it's very hard to get men, and we'll talk about that in a minute, is that this happens faster. So this is actually accelerated aging at the cellular level. The other thing that happens is that as these degrade, the chromosome itself unwinds like a slinky, and the pieces of the chromosome that shouldn't be exposed are exposed for transcription. That means that there are substances floating around in the bloodstream of people who have suffered abuse that shouldn't be there. So we see things like chronic inflammation. I actually, my most recent foray into this work has shown me that there are genes that contribute to the development of cervical cancer in women that become exposed as a result of this. It's called differential methylation, and so we are seeing an increased potential risk for cervical cancer in women who have experienced domestic violence. I know, right? So all of that is my way of being able to go to policymakers and say, look, there is a real effect here. There is a real effect on the health of your constituency because you are not attending to this. So as a scientist, what I really want are numbers. I want to be able to go to policymakers and say, this is happening. Okay, and I want to be able to take it with a quote unquote neutral issue like cervical cancer, which we can all agree is bad, and say, hello, let's do something about this. So as a scientist, I try to look at things from the perspective of, okay, what is really happening? How can I demonstrate that through scientific experimentation and investigation? And then what do I do with that information? So that I can actually stand up here and tell you there is a link between intimate partner violence and cervical cancer, which we can all agree is bad. So that is my perspective as a scientist, that we have to understand the biomechanics of what is actually going on for people, because we know as advocates and as policymakers and lawyers and clinicians, we know that people who are affected by intimate partner violence don't get better. And I wanted to know why. So I got into nursing. And one of the things that I encountered early on in nursing that I think is so relevant to what Lee has been talking about is the nursing perspective on ethical behavior. And we have in nursing, we have a code of ethics. Most of the professions do, as does law, as does medicine, et cetera, et cetera. And we, within our code, we adhere to some principles of medical ethics that were laid out by actually someone I know, Childress and Beauchamp, who are fantastic medical ethicists. And I had the privilege of working with Dr. Childress a bit when I was at the University of Virginia. And one of the things that fits into this perspective, there are a number of principles of biomedical ethics. I'm not going to go into all of them, but the three that stood out to me as I was listening to Lee talk are autonomy, beneficence, and non-maleficence. Autonomy is basically personal agency, the provision for someone to make their own decisions, to have the appropriate information to do so, to have the space to do so, and to have the ability to do so. Beneficence is doing good. So in nursing, we interpret that as we are not going to do something that is going to hurt someone. And then the companion to that is non-maleficence, which is not intentionally doing something bad. Now, the reason that we have these guiding principles for our profession is that it sometimes is very difficult to know what's what. For example, if you need to obtain consent from a patient for a procedure that you know is going to help them, but it's going to hurt them, you have to determine how you can best respect their autonomy in making the decision to consent to the procedure. How is the procedure really benefiting them? And is it possible that in getting them to consent to this procedure, which you know is going to help them in some way, potentially going to harm them in some way as well? And I think that all of those things collide when we talk about mandatory arrest and services for survivors and support for people and interactions with law enforcement. And so understanding whether or not we are respecting a survivor's autonomy. I struggle because as healthcare providers, we are mandatory reporters in the state of California. California is one of the only states in the union where we have to report domestic violence, no matter the age of the person. Many states, mandatory reporting is only for children and elders, and in our state, we have to report everything. So the statutes are a little bit bizarre, as some of you probably are well aware. What they say, what the statute actually says, is that if you are a healthcare provider and you are providing treatment to someone for an injury that you know to have been caused by abuse or assault, you have to call the police and file a report. This gets widely misinterpreted. We have people calling the police because their patient told them that they had experienced domestic violence. That does not actually warrant a report. We have people calling the police because their patient told them that they had a previous abusive experience when they were, 10 years ago, something like that. That also does not warrant a report, and it is a gross misuse of resources to dump all of that on law enforcement for many reasons. One, many of these cases can't be investigated. Two, there are so many reports that are unnecessary that the ones that may be necessary sometimes aren't even noticed, because there's an overwhelming number of people making reports that aren't necessary. So I try to consider all of those things from the perspective of someone who, as a healthcare provider, is trying to behave in both an ethical and legal manner. I want to report if I'm supposed to report, but I also need to do what is the most beneficial, respectful, and non-harmful to the patient in front of me. And I think that gets lost very often when we are dealing with domestic violence, because as Lee so helpfully pointed out, it is this intersection of criminal legal proceedings and health and advocacy at the same time. I have this big X on my note sheet here because I was like, okay, here, this is where we intersect, and then how do we handle that intersection? We can't work in silos. We have to have the science as well as the law in order to deal with this issue. And we cannot overlook the fact that those things necessarily intersect, and we have to address that intersection anytime we seek solutions. So from that perspective, we move to my clinical practice. I practice here in Orange County as a forensic nurse. Anybody know what that means? Thanks, Lee. Bless your heart. So I am the person that gets called in when someone's body is the evidence. This is in cases of violence, abuse, sexual assault. I actually don't practice pediatrics, but there are nurses who do sexual abuse and child abuse cases as well. So I am the person who will provide care and collect evidence in that case. It's a very interesting line to walk in trying to provide what I know to be good clinical nursing care, and also to adhere to the guidelines set out by the state for me for collecting and documenting evidence of an assault. And so we struggle. And I struggle a lot personally because for me what matters is the patient in front of me. And I struggle very often because law enforcement is so much more concerned with the evidence that they've forgotten that this is a person sometimes. And with administrators who look at my charting and say this is not complete, and I say, well, it wasn't really appropriate for me to complete it, and here's why. Because it was not okay for the patient at that time for me to do that. And so we have this bizarre dichotomization of care and respect and evidentiary burden, where I'm doing the very best I can for this patient in front of me, but the state crime lab and the police detectives and the eventual judicial folks are more concerned with what's over here in this evidentiary bundle that I create. And so it's hard for us as clinicians to walk that line in terms of how do we participate in both those systems at the same time. There are not that many of us. There are not that many forensic nurses in the country, let alone Orange County. I think I know all of them in Orange County. So understanding how we operate across and between those two realms is very challenging. But I think that it is a vitally important part of the work that Lee is doing and the work that you'll hear from the rest of the panel here, and the work that we need to do together as a community. Because not only do we need to talk more about this, as Mimi said, we have to get this issue out of the private sector and into the public sector as much as we can, just to get people talking about it. But we also have to recognize all of the parts of it. And as nurses, we take what I call a holistic perspective. We don't just think about the evidentiary burden. We don't just think about the telomere shortening. We don't just think about the epidemic of sexual violence in this country. We have to look at all of that, because if I don't look at all of that, I can't care for the person in front of me. I can't appropriately attend to their needs, respect their autonomy, provide them with beneficence and practice non-maleficence, all at the same time. So understanding that there is not just one perspective on this, and that in order to be successful, we have to bring together all of our perspectives and all of our efforts and understand where they overlap and what our strengths are and what we each can contribute to this mess as we try to improve it. And so I think the work that Lee has done with this book is really a wonderful step in the right direction, and I hope that it will be sort of taken up by sectors other than just the criminal legal sector of the anti-violence movement. There are a few other things I want to say, Jane. I have no idea how long I've been talking. 5 more minutes, okay. A couple of things that I wanted to point out as I was listening to the speakers earlier is that we also do something really stupid in the anti-violence movement, in that we try to say that domestic violence and sexual assault are not the same thing, or that they need to be separated somehow. Yeah, we got different laws about them, but they occur together all the time. I think Mimi mentioned reproductive coercion when she was talking, and that's a place where those things merge most directly. Where we start to understand that power and control over someone isn't just about controlling them in that relationship, satisfying that need for control or need to control one's environment by controlling another person, but also controlling bodies and how bodies operate and what bodies are used for. And that to me ties back into what we often call toxic masculinity, where women's bodies are different than men's bodies, or bodies that can bear children are different than bodies that cannot. And that somehow, for some reason, bodies that can bear children are considered less than. Did you know we couldn't even do clinical trials research on women in this country until 1978? It was illegal. And it is only within the last 10 years that NIH has issued a policy saying that you must include women in your medical research, no matter what it is. The pill was tested on men. Tell me that makes sense. But there is the flip side of that, which is toxic femininity. And we use that to reinforce some of what leads to the situation that we find ourselves in this country at the moment. 53% of white women voted for Trump. I know, right? And it didn't go any better on Tuesday. There is a silencing of women by other women. There is judgment of women by other women. And I know I have to sit down, but I want to tell you one last story. I had a patient come to me as a forensic nurse. She had been raped. She was brought in by a female law enforcement officer. She was distraught, obviously. She had had a really bizarre experience where she had tried to file a police report and couldn't get anyone to listen to her. And then she had gone to Planned Parenthood to get testing for sexually transmitted infections because she was concerned about that, had a conversation with someone at Planned Parenthood, went back to try to report to the police, and ended up in front of me. And to my horror, the female police officer said to her, "Well, why do you have this birth control if you weren't going to have sex with him?" So I took a deep breath and I tried to respect my patient's autonomy and let her handle that the way she wanted to. And when she looked at me beseechingly, I put on my professor hat. And I said, well, actually, there are a lot of reasons to have birth control that have nothing to do with sex. Many women use it for hormonal reasons to control migraines or their periods. There's something called dysmenorrhea. I could go on. And I did for about 10 minutes in my best professor voice. So I think that there are things we have to confront that we don't want to confront. We don't like the idea that it's a not all women situation. We don't like the idea that we are not all on the same page. But we cannot proceed to create a community, a country, a world in which we remove the impact of intimate partner violence and sexual assault if we don't come together and look at this holistically and collectively. Thank you.